very good afternoon to all and warm welcome. It's my great pleasure, privilege, and part to be here this great afternoon. I'm Mitesh Lohar, Regional Clinical Manager for Polymedicure. I would like to welcome you all on this platform. See, we are heading this Infusion Nurses Society Gujarat chapter very nicely. I'm really proud of having the part of this Infusion Nurses Society. With this, I would like to welcome Miss Papia Chatterjee, ma'am. She is currently heading the nursing services at HCG Cancer Center, Ahmedabad. To take this session forward, I would like to hand over the session to Papia, ma'am. Ma'am.
Thank you, Mitesh. Please share the screen or else I have to do.
Manjunathan, sir, you are sharing, yeah.
Hello. Hello.
Full
I hope
view.
the screen is visible.
Visible, yes, yes, visible.
Yes. So, Namaste, ma'am. It's like we are feeling grateful that Madam is here with the very busy schedule. Namaste, Vinu, ma'am, and all other dignitaries, Manjunathan and Ullash and audience and the MC members. So it's a great pleasure that we can start this within all of your busy schedule at a very short notice of like with all of us. So I'm just giving an overview of INS and I will tell a few things for ma'am, Colonel Binu ma'am, who is actually like Madam is the INS president and India, and Madam is our inspiration to start Gujarat City Chapter. And this is like with her blessings and all, we will going to start this forum today. So what is INS India? The Infusion Nurses Society is committed to bringing the innovative new resources and opportunities to a wide range of healthcare professionals who are involved with the practice of infusion therapy. In this new world of rapid technological advances and dramatic shifts in healthcare delivery, INS, Infusion Nurses Society, is setting the standard of dedicated clinicians who seek to provide excellent infusion care across all practice settings. We invite you to be a part of community that sets the standard for infusion nursing. As the premier professional organization for infusion nursing, INS is your and our ultimate resource for successful infusion practice. Whether you work in the hospital, in home care, in an ambulatory infusion center, whether you are an infusion nurse specialist, a pharmacist, a generalist nurse, or a nursing student, INS Infusion Nurses Society strive to support your commitment to high quality infusion care. The Infusion Nurses Society, located at Norwood, MA, is a national non-profit organization founded in 1973. It is in US as the so INS US, INS India is affiliated with INS US. INS India is an international affiliate of INS US, formed by a group of like-minded healthcare professionals as they joined hands-on standardization infusion therapy practices in the country. The membership is open and to all healthcare professionals from all practice settings. And in Gujarat, you can contact any of us, me, Manjunathan, Ullash, and Mitesh, our BD and 3M, the partners and all. We all are here to help you out for taking membership. and how to take the infusion therapy, the quality and standard of infusion therapy, how to take the lead in this. And Gujarat nurses will be blessed, I feel. We are only working at our workplace, but we don't know that much where actually infusion stands. Now, it's a very important moment to to speak for Madam Colonel Binu Sharma, who is President of INS India. So, Madam, it's heartiest welcome to you from all of us from Gujarat State Chapter. So, I am feeling grateful that I got the opportunity to see you and to tell regarding your vast profile. You may have written in one slide. I know you, how you are. So it's our great opportunity to view in this forum and to speak a few sentences for you. So Madam is President INS India, US affiliated Senior Vice President Nursing Service. Madam is affiliated with Columbia Hospitals India. He is a recipient of Torchbearer Award for Nursing Leadership, recipient of Women Achiever Award, recipient of Nightingale Award, Best All-Round Officers Trophy, Indian Army, Commendation of Medical and Exemplary Services, Nursing Eastern Command, Indian Army, Certified NABH Nursing Excellence Assessor, Internal Assessor JCI, President for INS India, Founder Member Association of Nurse Executives India, Chairperson of Nursing Research and Leadership, CAHO. Madam is in advisory panel of nursing work for FICCI. So Madam, over to you for a few sentences, please.
Thank you, first of all, Ms. Papia, for a very, very honored introduction for myself. And I am humbled by the introduction for me. I really respect each one of you for devoting and contributing your time to the patient safety endeavors. As Infusion Nurses Society India is an endeavor towards improving infusion safety and overall patient safety in the country. INS India is a non-profit association or society, and the sole vision and mission of INS India is achieving patient safety through training and building knowledge and skills of our dear Indian nurses through the India chapter. We are affiliated to the US, and there are so many other countries who are affiliated to the US. But I can proudly say in the last 10 years, we are just about 10 years old in the country for INS. In the last 10 years, we have made a lot of inroads. We have achieved a lot of milestones, and we have crossed so many successful events with the help of each one of you. We have multiple chapters in the country, and talking about INS Gujarat, we started with INS Ahmedabad chapter just 2-3 years ago with the help of our industry partners. And in this, Polymed took the lead of identifying many of you very active and hardworking nurse leaders from Ahmedabad. And over time, in last 2 to 3 years, we actually were able to convert the Gujarat chapter, the Ahmedabad chapter to Gujarat chapter. That only shows the willingness, the contribution, the passion, all of you nurse leaders towards achieving patient safety. And all of you will know that we are almost entering the month of September, which will also embark a journey of World Patient Safety starting 17th September. So it is a great time. Can I request audience to be on mute, please? Audience, please mute. There's somebody talking. Audience, please mute. Thank you. So it is a great, proud and happy moment for me to see the progress of INS Gujarat. Chapter. And today, under the leadership of the new bearers, office bearer team, we are having the first meeting between nearly 70 people in the call. I'm so happy to see a large number join today. So first of all, let me announce the office bearers or the leadership team of INS Gujarat. The chairperson is Ms. Papia Chatterjee. Heartiest congratulations to you, Ms. Papia Chatterjee. And thank you very much for accepting this position, because it will need a lot of hard work and time from your end. Heartiest congratulations to you. I also congratulate Mr. Ulas from Surat. He is going to be our co-chair supporting these activities. So congratulations, Mr. Ulas, to you. And third, but not the least, Mr. Manjunath, who is part of our editorial board as an editorial board member. The editorial board will be instrumental in looking at all these scientific papers, journals, research papers, the iNews, which is an electronic newsletter. So congratulations, Mr. Manjunath. And so all of you, a great congratulations for you for taking up these roles and helping INS India, helping the General Council of INS India to achieve its mission and vision through each one of you. I alone stand nowhere unless all of you are standing with me. You know, it is known as a leader is not a leader till the leader has followers. So Gandhi ji had a lot of followers wherever he was walking, even though he was walking barefoot and with his dhoti and with his stick. You see the number of people who were following him in every endeavor. So a leader can only become a leader can only achieve and contribute if he has a great team of followers. So thank you all of you for being the followers for INS India, for living our dream through your eyes, through your ears, through your contribution, and through your efforts. And I thank the entire MC team of INS Gujarat. I have got the names apart from the office bearers, apart from the industry partners from 3M, from BD, and from Polymedicure. We have got Aarti, we have got Dr. Pragna, we've got Hina Vyas, we've got Poonam Talreja, we've got Ritu Raj, we've got Sini, we've got Sonali Prajapati, we've got Tejal, we've got Tirupati, we've got Kirtan, and there's one number, I'm sorry, I don't recognize who is the person. So thank you, each one of you from the MC for being part of this, for driving INS India. And I look forward to a great session today. And I really look forward to Gujarat being my best chapter across India. Why do I say that? Because I've seen a lot of progress from the Gujarat chapter, a lot of interest from each one of you. So all the very best to all of you for today. Have a great event today. I may not be able to stay for a long time. I may exit in between the sessions, but thank you and all the very best to each one of you. Thank you for having me over. Namaste.
Thank you. Namaste.
Thank you, ma'am. Namaste, ma'am.
Thank you, ma'am.
Thank you, ma'am.
Ma'am, thank you very much. And a wonderful opportunity, all of us. We got such an eminent, the president, to start this INS in Gujarat. Rightly you said, ma'am, our MC members and all the Gujarat nursing leaders have wonderful platform, and they are very active to start this INS, and still we will take up this into the next level. Namaste all, and to God be glory for a great things he has done. Infinite joy and delight is filled in this arena with the presence of the eminent Colonel Binu Sharma, guest, and our own family members of INS. On this harmonious day, we, the INS family, welcomes all the dignitaries, delegates, and participants in this forum. We are at the edge to leap into a splendid, fabulous, amazing, dazzling, and electrifying a day ahead. Today, we have gathered here to learn and enhance our knowledge and abilities as nurses to aid our community towards better living. Benjamin Franklin said, "Genius without education is like silver in the mine. Therefore, let us join hands so that we may become shining silver in the lives of patients." In this forum, I would like to invite all our pillars and founding members as a MC members in this forum, and I request each one of you to present your existence in the infusion practice, which they're going to set benchmarks and to create our own evidence-based practice. First, I would like to call upon our MC members to present their perspective of practices. I would like to call Ms. Papia Chatterjee, Nursing Head, HCG Hospital, Ahmedabad.
Thank you, Manjunathan.
Pleasure, ma'am.
Ma'am, you are on mute, Papia ma'am.
I know, but I am waiting to for the slide. I feel Manjunathan will share.
Yes, ma'am. I would like to share. Yeah,
Yes, please.
ma'am. Is it visible? Ma'am,
you are on mute.
You are
Yes.
on mute.
If you can it's in a maximize, you can like shorten it, that will be better, because my screen are on right side, so the half of the letter are I couldn't able to see. Don't do F5. Is fine. So in this, I have joined HCG hospital just before an year, just completing 1 year in this month. So I couldn't able to do that much, which I can able to do for next few months, which I can be able to do. So there are few members who already has taken membership, and we just started sharing awareness for this. And what we did for infusion therapy, there are exhibitions and all we have started. We have told about INS, the society and all to our staff. We have nearly 100 staff here. So I feel we will expecting more and more numbers of membership. So as a chairperson has to wish conduct next national conference in Gujarat and target membership for all over Gujarat with by holding all of your hands and the very excellent team of MC members, and with me, Ullash and Manjunathan, and Madam is always her blessings, her hand, her, as a mentor, Madam will help me. So I feel we can achieve the target of 1,000 membership from Gujarat. So that's all. I couldn't able to do that much in HCG for last 1 year. So I will do. So that's a promise from my side. I can tell I have started this from my previous organization, Zydus. So many members were there. That way we have started the Ahmedabad city chapter. So now going forward to add more membership from my own organization and all state.
So may I just add a sentence here, Papia?
Yes,
I urge all the people in the call, the nurse leaders, to very seriously look at the lifetime membership of INS India for one additional reason. The additional reason is in this year's annual conference, I had made an announcement. If you attended the annual conference, I made an announcement that INS India will be doing certification programs related to infusions. And right now we are in the process of developing 12 certification programs on the platform of INS India. These are being developed with the help of specialty consultant and specialty nursing teams from across the country and from even outside India. There are 12 programs. There is a comprehensive program on vascular device management, right from peripheral cannulation devices to central line management, arterial line management, dialysis, catheter management. So we have sharp injuries, we've got on biomedical waste management. There are all together 12 certificate programs which are going to be available to each one of you free of cost if you are a lifetime member. These programs will be hosted on the INS India website. And once you come to the website, you will be taken to the portal of the certification program as and when you wish to do these online certifications, which are going to be complimentary. We are spending about more than 20 lakh rupees in developing these certificate programs. So my request to you all is please encourage practicing nurses, nurse educators, charge nurses, ICU nurses, infection control nurses, the nurse managers to actually go ahead and become members. They will be able to get the benefit of having 12 certified programs in their profile, which are all going to be complimentary for them. And these are all going to be endorsed by INS, which is a global authority in the infusion standard. So this is one additional reason to become a member. These programs will be available November onwards this year. Thank you for listening to me.
Thank you, ma'am. It's a very important information. We will carry forward and we will share with all our all junior nurses and all within our organization and throughout the state.
Yeah, thank you.
Next, our MC member, Mr. Ullas Udayan, Chief Nursing Officer and Quality Head, Srimati Rasila Ben Savantilal Shah, Venus Hospital from Surat. So, yeah, welcome, Mr. Ullas.
Thank you, Majidar sir. Yeah, good evening, everyone. Actually, my achievement in the last year is not my achievement, the achievement of nursing leaders in Surat. Actually, we gathered into a single platform with the help of different pharmaceutical companies and we formulated a nursing leader forum in Surat. Actually, we are about to convert the same forum into INS. It is around 100 members currently, and everyone are very interested to be a part of INS. So we hope we will be formulating a Surat City chapter in the coming couple of months. And the next one we are planning in every leaders in the already we gathered around 15 hospital nursing leaders and around 5 academic nursing colleges. We gathered into a single platform and we will be campaigning for the INS membership. And we hope we will be having minimum of 500 members from Surat City in the coming 2 years of time. That is my target in the 2021.
Thank you, Mr. Ullas. Such a wonderful planning, and requesting all the MC members to take a call to wind up within 2 minutes of your just unfolding whatever your existence and the current plannings. And now I would like to call Ms. Aarti Pandya, a nursing head from HCG Hospital, Ahmedabad.
Good afternoon.
Yes, Ms. Aarti.
Namaste, ma'am. Regarding my last year achievement, I would like to say that we have focused on the cleaning and disinfection of the equipments used for the infusion therapy. And we have done a project on that, and which shows a very positive result, and we were able to reduce the phlebitis rate in a good number. So that was a last year achievement, and this year for planning 21-22, a new project on flushing and locking has been initiated, maximum participation of the nurse lead will be emphasized toward the safe infusion practices. And furthermore, the plan is to encourage maximum staff to take the membership of INS and learn more about the safe infusion therapy. Thank you very much.
Thank you, Ms. Aarti. Such a wonderful planning. But still, in addition to that, expecting all the MC members to take the research call to getting the data and setting evidence-based practices to practice our own standards in INS India Forum. I would request now Ms. Sonal Prajapati, Nursing Superintendent, GCS Medical College and Hospital, Ahmedabad. Yes, Ms. Sonal. So, Sonal, you are there online? Yes. Next, I would like to call, and it is my own personal glad to invite Ms. Trupti Patel, Nursing Superintendent, Apollo Hospitals International Limited, Gandhinagar. Yes, ma'am.
Good afternoon, everyone, and especially thanks to Colonel Binu ma'am, Chairperson Ms. Papia, Mr. Ullas, and Manjulathan. After a long time, I have joined this session in INS, but I am thankful to INS society and everyone. I would like to add one thing that I have the 25 years experience, but when I joined the nursing field, and at that time, I think that very small procedure, IV cannulation is very small procedure. But after later on, after getting the experience, I came to know that this small procedures leads to big infection to the patient, and patient gets the phlebitis. When I was student and beginning of the staff nurses role, I couldn't know that how many complications were happening with the patient with wrong practices and without hand washing and any other following the process. So today I am a nursing superintendent in Apollo Hospital. So I also think that my nurses. Hello.
Hello.
Please unmute. Please rest of the MC members and the participant requesting you to unmute. Sir, keep the mute.
Can I start?
Yes, ma'am. Yes, ma'am.
Okay. So today I working as a nursing superintendent, and I always think that how my nurses will be good in taking the IV cannulation and IV therapy. So last year, evidence and performance of last annum, the year 2020 to 21 was hectic and quite challenging for all of the leaders and all the leaders of all the world, as COVID-19 is a pandemic. So last year we have taken the project that effectiveness of a visual infusion phlebitis scale for determining appropriate discontinuation of peripheral intravascular catheters. So a frequent PIVC complication is phlebitis. That is inflammation of the vein, which may be mechanical, chemical, or bacterial in origin. Phlebitis causes a cascade of unwelcome repercussions, significant pain, failure of the peripheral IV catheter, closely monitored, and it was closely monitored with VIP score, visual infusion phlebitis score. And we got the result. Our study reveals that the appropriate observation and clinical condition were help us to monitor the incidence of PIV. Our incidence were 7%. And VIP skills were implemented on ground and closely monitored by the nursing in charges and senior nursing, and it brought down 4.8%. So we try to maintaining, and consistency would be maintained by all the nurses. We have taken the reference that 5% incidence rate of phlebitis as an acceptable benchmark. In 2002, the CDC guideline that PIV sites and admission sets be changed at least every 96 hours. Yet clinical practice supported that at least 25% of PIV catheters showed no sign of phlebitis at 96 hours dwelling time. So this is the study, and we are happy that we cut the phlebitis, and our patients' outcomes is good, and getting the good feedback from the patients. So our next plan in 2021 to 2022, As in INS, there are 9 chapters. So we select section 5, vascular access device selection and placement. We had a concern on vascular access and device management on bedside. And we have developed FMEA process to identify the lapses on below feedbacks. We collected the feedbacks from various stakeholders like consultants, then ICNs, then patient feedbacks and nurses feedbacks also, and audit data. So by this way we got the feedback that still we need to improve ourselves. So it was identified the gaps of 50%. On the basis of evidence we developed new process and checklist, and also made an awareness and training among all nurses and implemented on ground to take up the process on practice. We have taken 150 samples taken accordingly to the parameters which is given in the checklist. The data shows inclination of vascular access management. It is approximately 70% as of now and will complete by end of the December 2021 to set an evidence-based practices. So our target should be more than 90%. So we all are trying behind that and taking the rounds and guiding the nurses, and demonstration wise IV cannulation process would be there at the time of joining for new freshers nurses. As now new nurses has done the experience of the IV cannulation, so we demonstrate everything and then we give the patient to them. So this is our unfold plan, and thank you so much everyone.
Thank you, ma'am. Such a wonderful information and sharing knowledge with all of us. This is how the INS is expecting from each one of us. These evidences we need to create and do the publications, and which we may publish ourselves to set a evidence base to practice in a clinical outcomes. Thank you, ma'am. Thanks, and thank you very much. Yeah. Now I would like to request Ms. Tejal Chauhan, Deputy Nursing Superintendent, SVP Hospital, Ahmedabad. Yes, Ms. Tejal.
Good afternoon, everyone. Am I audible?
Yes, yes, please go ahead.
Yeah, thank you, Manjunathanji.
Thank you.
Myself, Tejal Padaria. I'm working here as a Deputy Nursing Superintendent at the SVP IMSR in Ahmedabad. The last year during the pandemic, it was a whole year we were declared as a COVID care center, and we were getting only a patient of COVID. So that time when we attended last time INS conference, and we have told by Binu ma'am and all that we have to do something, we have to set the standard in our organization. So we have selected the very simple project of phlebitis. As Srupti madam nicely explained that when we were students and when even we were a staff, we feel that IV cannulation is a very small procedure. But all the admitted IP patients have the IV line. And that is why we have selected the IV cannulation care. And initially when we started taking round in a COVID, we got to know that the nurses are not, concentrating on IV cannula, though it was a condition where all the patients and clients are on the oral medication, but IV cannulation was always there. And the number of phlebitis were very high. So we have taken care of this project, and mainly we have focused that how to select the insertion site, how to select the device, securement technique, and we have also checked the irritating solution. We have had the meeting with the pharmacotherapeutic committee, and we have listed out the drug list which cannot be given by the peripheral IV line. And through this all parameter, we have achieved that number of the phlebitis 1 in 200 patient, which is as of now, as per the standard norms, it can be up to 5%, but we have reached around 2%. So it is a nice achievement at our organization. And for the futuristic plan in 2021-22, we have to have a major focus in our organization under INS will be a safe injection practice. We have a teaching institute, and the multiple factors are affecting to set the standard, but the safe injection practice is selected because because the injections, every alternative patients are on IV cannulation. I can say the 100% patients are on IV line, but sometimes in medical ward there will not be IV injection, but injection practices are must for the all nurses. So we have we have planned the project in the future about the safe injection practices. Will come with a good result in near future. Thank you so much.
You are on mute, Mr. Manjunath.
Thank you, Ms. Tejal. Thank you for sharing your phlebitis with achievements. 1 in 200 patients. Really, it is a great achievement what you held at SVP. And looking forward to taking data and sharing all the safe practices and setting standards in infusion therapy. And that will take up into the publications and also the magazines which we are going to publish through INS India. So that is, these things will more helpful for us to take up. So once again, be online, please, 2 seconds. Yeah, sorry for the interruption. Now I would like to request Ms. Poonam Talreja, Deputy Nursing Superintendent, Apollo CBC Cancer Care, Apollo Hospital, Ahmedabad. Yes, Ms. Poonam.
Namaste, sir. Namaste to all. First, I thanks to INS and Mitesh and Manjunath sir, and special thanks to Colonel Binu Sharma for giving me this opportunity. In last year, in last 2020 and 21, was the spotlight and highly nurses were recognized by across the globe, and in that year we did 2 clinical audits. First audit was on monitoring of port flushing technique in chemotherapy patient, and this observation is because of the observations of occlusion, infection, mechanical dysfunction, and accidental delining of tubes are tried to do this audit. And in this audit, it is one of the most frequently employed venous access for administration of chemotherapy and supportive care. To prevent late complication, the latest guideline recommended to flushing or locking procedure every 4 weeks. It is differ in some of the guidelines. Some of the guidelines say 6 weeks or 8 weeks, but we follow 4 weeks flushing as per our consultant's advice. And after audit, the results were conducted pre-test, and the results was revealed 33.3%. Then we did the gap analysis. It was resulted for training, observation, and continued monitoring. And we plan was training and implement the and conducted the post test, and the result was 87.5%. It shows the skill and knowledge upgrade among the nurses, and because of that, we have 0 reporting of port infection, and it is a sustenance and control plan to continue this practice. The second audit we did for the prevention of thrombophlebitis. In that, after continuing monitoring training, we got that the patient were discharged with no phlebitis were increased by 17%, and the second grade of phlebitis was decreased by 18%. This was a great achievement in last year, and it was already continued study and monitoring is going on. In this year, we planned as per INS chapter section 6, vascular access device management. The 6th INS chapter, it says that vascular access device management, and also it was a major concern in the proximity of oncology department. This study were taken on the basis of patient outcome, consultant and nurses feedback. The problems were understood with Pareto analysis, and we are ongoing on study the care and maintenance of central lines. And till date we taken 64 samples till date, and looking at the parameters and dimensions shows inclination of care and maintenance as per the expected target of benchmark. This study will complete by end of December in this year and can be set in evidence-based practices. Thank you so much.
Thank you, Ms. Poonam. Really, these informations and the shared, the detailed way of analysis will help us to set the standards across the oncology patients, and also the non-onco and NCDs. It may help us to, spread across the multi-speciality unit as well. Really, it is a wonderful information for all of us. Please keep up doing, and this will help us to do the publications in the E as well. The magazines which we are going to take up into the next project. Thank you very much.
Manjunathan sir, you are on mute.
The slides are visible?
Yes.
Okay, great. Because this slide is basically a PDF slide, so it could not be able to display a full desktop. So here I would like to welcome Ms. Nirali Patel, infection control nurse, and she has completed her general nursing and midwifery from GNC, and the certification, she has done certification courses on infection control practices, and she has more than 8 years of experience, and also she has experience and exposure of NABH. We would like to welcome Ms. Nirali. Please take over.
Can you please share the presentation of Ms. Nirali?
Yeah, this is the presentation.
It's not Nirali's presentation, it's presentation of Poonam.
One second.
Hello. Can I share my screen?
Yes,
yeah, you share it. You share it. I'm not able to share your slides.
Hello.
Yeah, please carry on.
Manjunathan sir, you have to stop your sharing.
Yeah, please, we are not sharing because of this, someone is shared the screens.
Hello. I cannot start my screen share.
Right, one second. Yeah, please carry on.
Yes. Hello, I am audible enough?
Yes.
Shall I start?
Yes, please.
Okay, already my introduction is given so nicely by Manjunathan sir. Just myself is Nirali, working as an ICN in Nirali Cancer Hospital, Navsari. I'm having more than 8 years of experience. Today, my topic will be improving the safety of peripheral IVs with novel technology. Improve the safety that ultimate the improve of safety of patients and staff. So we have some observation. ये जैसे कि हम बोलते हैं कि हर एक हॉस्पिटल में ऐसा कुछ ना कुछ ऑब्जर्वेशंस ऐसे रहते ही है, तो हम रिगार्डिंग इसके बारे में ही बात करेंगे आज. तो जैसे कि हम बेसिक से स्टार्ट करेंगे, आईवी कैन्युलेशन एंड जैसे मेडिकेशन देते हैं तो हम ट्रे में क्या प्रिपेयर करते हैं. तो फर्स्ट है कैन्युला, डिफरेंट साइज ऑफ NS फ्लश वी आर यूजिंग. फिर है वेनोलाइन, वाइट कैप कनेक्टर या जैसे 3 वेज बोलते हैं, IV सेट्स, IV पॉइंट्स, ड्रेसिंग, इजी फिक्स, ग्लव्स, हैंड रब, हैंड सैनिटाइजर. ये सब चीज, बहुत सारी चीजें हम ट्रे में लेके जाते हैं ड्यूरिंग IV कैन्युलेशन एंड मेडिकेशन के लिए. तो आज हम ये 6 पॉइंट है, इसके बारे में जो न्यू टेक्नोलॉजी है उसके रिगार्डिंग हम बात करेंगे. फर्स्ट है हमारा कैन्यूला। जैसे कि हम कैन्यूला जो भी यूज करते हैं उसमें प्रोबेबल रिस्क है वाइल कैन्यूलेशन शार्प इंजरी होने का, और वो शार्प इंजरी पेशेंट और स्टाफ किसी को भी हो सकता है। तो और दूसरा एक चीज है, जैसे कि हम एक बार प्रिक करते हैं स्टीलेट बेड साइड पे, जैसे अनक्लीन सरफेस है वहां पे रखेंगे और फिर वापस वो प्रिक में नहीं आया तो री इंसर्ट करते हैं वही स्टीलेट और वापस पेशेंट को दूसरा प्रिक करते हैं, तो देयर विल बी अ चांस फॉर कंटामिनेशन एंड इन्फेक्शन। सो उसका सॉल्यूशन ये है कि हम क्या कर सकते हैं। तो एक है सेफ्टी कैन्यूला, वी कैन यूज सेफ्टी कैन्यूला। उसमें ऐसा है कि वंस इट विथड्रॉ देन यू कैन नॉट री इंसर्ट नहीं कर सकते, और री इंसर्ट नहीं करोगे और ऊपर से अल्टीमेट प्रिवेंशन ऑफ शार्प इंजरी। जैसे कि आपने देखा होगा इमेज है उसमें एक डिवाइस, जैसे आप विथड्रॉ करते हो एक इमेजेस आ जाती है आगे डिवाइस टिप के पास में, तो आपको नीडल स्टिक नहीं हो पाएगा और री इंसर्ट नहीं होने की वजह से कंटामिनेशन का चांस नहीं रहेगा। दूसरा टॉपिक है हमारा, दूसरा एक है फ्लशिंग ऑफ कैन्यूला। जो हम फ्लश करते हैं, यूजुअली हम फ्लश के लिए क्या यूज करते हैं, तो जनरली हम NS 100 ml है जो एज अ मल्टी डोज वायल हम यूज करते हैं, या फिर हिपेरिन सलाइन कोई कोई जगह पे यूज करते हैं। हर बार NS जब भी फ्लश करना है एक न्यू सिरिंज ओपन करना पड़ता है और न्यू नीडल यूज करना पड़ता है। तो इससे क्या होगा, देयर इज अ प्रोबेबल रिस्क फॉर नीडल स्टिक इंजरी। जो भी स्टाफ और पेशेंट को नीडल स्टिक इंजरी का चांसेस रहेगा। और आप जो मल्टी डोज वायल यूज कर रहे हो, जैसे NS 100 ml हम यूज कर रहे हैं 24 आवर्स में हम डिस्कार्ड कर देते हैं, लेकिन सिंगल यूज डिवाइस इज मोर प्रेफर देन मल्टी डोज वायल। सो रिस्क ऑफ कंटामिनेशन ज्यादा रहेगा पेशेंट को। और हम कोई कोई जगह पे हिपेरिन यूज करते हैं, तो हिपेरिन के डोज इनएक्यूरेट होने की वजह से चांस फॉर एडवर्स इवेंट होने के चांसेस रहेंगे। सो इसका सॉल्यूशन ये है कि आप यूज ऑफ प्रीफिल्ड सिरिंज, बहुत सारी कंपनी की प्रीफिल्ड सिरिंज अवेलेबल है, तो इजी है यूज करने में, स्टेरिलिटी मेंटेन होता है इसमें, टाइम कंज्यूमिंग है, स्टाफ को इतना टाइम वेस्ट नहीं करना पड़ेगा, लोड करो और वापस दो इसमें। दूसरा है रिड्यूस द रिस्क ऑफ मेडिकेशन एरर, जैसे कि 2 इंजेक्शन के बीच में हम फ्लश करने का रिक्वायरमेंट है, ड्रग इंटरेक्शन नहीं हो, तो अगर इजीली अवेलेबल है तो हम यूज करेंगे। और दूसरा है अल्टीमेटली पेशेंट का जो भी आउटकम है वो इम्प्रूव होगा, और नीडल यूज नहीं होती है इसमें प्रीफिल सिरिंज में, तो शार्प इंजरी भी प्रिवेंट कर सकते हैं। थर्ड पॉइंट है हमारा जो वेनोलाइन, जो हम व्हाइट कैप कनेक्टर, आपने इमेज में देखा होगा व्हाइट कैप हम यूज करते हैं, तो देयर इज अ प्रोबेबल रिस्क फॉर कंटामिनेशन। जैसे कि व्हाइट कैप है ऑफन कॉज अ माइक्रो ऑर्गेनिज्म एंटरिंग द IV सिस्टम, जैसे कि पर्सन्स के हैंड हर बार हैंड सैनिटाइजर नहीं करते जब भी आप व्हाइट कैप हैंडल करते हो तब। दूसरा है आफ्टर कोई भी IV इंजेक्शन जो रेसिडुअल ब्लड है उसमें मल्टीप्लीकेशन होगा बैक्टीरिया का। दूसरा है बहुत सारी जगह पे हमने व्हाइट कैप देखा होगा जो रूटीन है, जैसे कि हमारे बेड साइड लॉकर पे है, हमारे कभी कभी स्टाफ के पॉकेट में व्हाइट कैप होती है, ड्रॉअर्स में होती है, तो उसका अल्टीमेटली चांस है पेशेंट को कंटामिनेशन होने का, इन्फेक्शन होने का। हेलो। देन फॉर अल्टीमेटली न्यू टेक्नोलॉजी ये है कि हम क्लोज पोर्ट यूज कर सकते हैं इसमें है इजी है, आपको क्लीन करने में आपको व्हाइट कैप की जरूरत नहीं पड़ेगी जो इधर उधर मिस हो जाती है। दूसरा उसमें जो ब्लड स्ट्रेन है वो प्रिवेंट हो सकता है, तो फॉर क्लोज पोर्ट मेंटेन हम कैप यूज कर सकते हैं। फोर्थ हमारे है IV सेट्स, जो हम IV सेट्स यूज करते हैं तो उसमें क्या होता है, देयर इज अ रिस्क फॉर पेशेंट विल नॉट गेटिंग प्रॉपर डोज ऑफ मेडिकेशन का प्रॉपर डोज नहीं मिलता, कुछ ना कुछ ml ऑफ मेडिसिन IV सेट्स में रह जाती है, और जैसे कि अगर हम भूल गए तुरंत ही बंद करने के लिए तो एयर पास हो सकती है, चांसेस है, तो हम उसकी जगह पे ऑटो एयर स्टॉप जो प्राइमिंग फिल्टर है विथ एयर वेंट वो यूज कर सकते हैं, जो अल्टीमेटली हमारा प्रिवेंट द एंट्री ऑफ एयर इन द फ्लूइड व्हेन IV बॉटल इज एम्प्टी, जैसे कि एम्प्टी होने के बाद एयर नहीं पास होगी। दूसरा है कंस्टेंट फ्लूइड लेवल मेंटेन होगा, एंड दूसरा है नो एयर कैन थ्रू द पेशेंट्स, एंश्योर द लाइन फिल विद ऑटोमेटिकली, आपका वेस्टेज जो फ्लूइड का वेस्ट है स्पिलेज है वो कम होगा। फिफ्थ है हमारे IV पॉइंट्स, जो हम IV पॉइंट्स यूज करते हैं तो वो है उसका प्रोबेबल रिस्क है, अगेन पेशेंट का जो भी है आपका मेडिसिन का फुल डोज उस पेशेंट को नहीं जाएगा, और दूसरा हम ऊपर से एयर वेंट के लिए हम ऊपर से प्रिक करते हैं, जैसे कि एनवायरमेंट की जो भी कंटामिनेशन एयर है वो थ्रू IV फ्लूइड्स जाती है पेशेंट की डायरेक्ट आईवी में, तो वो कंटामिनेशन के लिए हम क्या कर सकते हैं, तो जैसे ऑटो कोलैप्स बैग है जो रेडीली अवेलेबल है, तो हम वो यूज कर सकते हैं। उसमें इंजेक्शन आपको ऊपर से ऐड भी करने की जरूरत नहीं है, इंजेक्शन पोर्ट भी दिया हुआ है, तो हम कंटामिनेशन प्रिवेंट करने के लिए ये चीज यूज कर सकते हैं जो न्यू है टेक्नोलॉजी। एंड लास्ट है हमारा ड्रेसिंग एंड सिक्योरमेंट डिवाइसेस, जैसे कि प्रोबेबल रिस्क है, हम इजी फिक्स डायनाप्लास्ट फिक्स हम यूज करते हैं जो नॉन स्टेराइल है। दूसरा उसके लिए डिसलोकेशन ऑफ आईवी कैन्युला जल्दी होगा, और थ्रोम्बोफ्लेबाइटिस पेशेंट को चांसेस है थ्रोम्बोफ्लेबाइटिस होने का, तो उसमें है कि हम एक ट्रांसपेरेंट ड्रेसिंग है वो यूज कर सकते हैं, वो स्टेराइल होगा और इजी है, आप विजुअलाइज कर सकते हो। जो अर्ली स्टेज ऑफ फ्लेबाइटिस में आप विजुअलाइज करके वो पेशेंट का कैन्युला रिमूव कर सकते हो, यहाँ तक कि ये थ्रोम्बोफ्लेबाइटिस पेशेंट को हो जाए, वहां से बेटर है कि अर्ली स्टेज में हम रिकॉग्नाइज करके हम निकाल सकते हैं कैन्युला। तो ये है मेरे कुछ पॉइंट्स है जो हम बहुत सारी हॉस्पिटल्स में जो पुरानी मेथड यूज करते हैं, तो वो नई मेथड हम न्यू टेक्नोलॉजी डेवलप कर सकते हैं हॉस्पिटल में, जो अल्टीमेटली सेफ्टी ऑफ पेशेंट्स एंड स्टाफ होगा, उससे प्रिवेंशन ऑफ शार्प इंजरी जो पेशेंट और स्टाफ को है वो कम होगा। दैट्स ए प्रिवेंशन ऑफ कंटामिनेशन, प्रिवेंशन ऑफ थ्रोम्बोफ्लेबाइटिस, रिड्यूस द स्टाफ एनर्जी, जैसे कि बहुत सारी चीज में हमें बार बार कैन्युला लेने में आउट हो जा रहा है ऐसा, तो उसमें स्टाफ की एनर्जी बहुत वेस्ट होती है, तो वो हम कम कर सकते हैं। दूसरा अल्टीमेटली पेशेंट का हॉस्पिटल स्टे कम होगा, और है रिड्यूस द कॉस्ट ऑफ पेशेंट। अब भी आप सोचोगे नई टेक्नोलॉजी है कॉस्टली होगी तो पेशेंट को बहुत सारे कॉस्ट बेयर करने पड़ेंगे, लेकिन ऐसा है कि अगर एक टाइम अच्छी तरह से हमने मेंटेन कर लिया है, वन टाइम इन्वेस्टमेंट जैसा, कि वो कैन्युला उसका थोड़ा लंबा टाइम तक चलेगा, तो फिर चांसेस कम रहेगा पेशेंट को बार बार कैन्युला का न्यू कॉस्ट बेयर करने के लिए। तो टेक होम मैसेज है, सेफ्टी आईवी कैन्युला टू प्रिवेंट शार्प इंजरी, प्रीफिल सिरिंज हम यूज कर सकते हैं, क्लोज पोर्ट, ऑटो प्राइम आईवी सेट्स हम यूज कर सकते हैं, क्लोज आईवी पॉइंट्स एंड ट्रांसपेरेंट ड्रेसिंग। थैंक यू सो मच।
Thank you, Nirali. Very nice pictorial presentations, very informative. I hope our audience, got a very good novel technology to take up better practices on the ground. Here, I would like to add the PAV complications with the reported incidences up to 78% across all the populations who get admitted in the hospitals. And also, the current control system intercepts only 2% of drug administration errors, but the 60% of associated the life-threatening errors, it is due to only the IV therapy. The conventional general purpose infusion devices cannot limit doses or easily customized to a specific populations. So what I would like to tell you here, the novel technology whatsoever you listed down, you explained it, so that is more often has to be practiced on the bedside, which helps us to prevent the 60% of life-threatening associated infusion adverse effects, so that may save the patients. So the practicing of novel technology will help us to better outcome and also ensuring the standard and quality of practice. So thank you very much, Nirali. And I would like to request our audience to ask the questions if they have anything. Or requesting all the participants to drop your questions in a chat box. So end of the session, we will take up all the questions to answer. Now I would request to call upon Ms. Tanvi Bhatia. Ms. Tanvi has completed her BSc Nursing from Gujarat University and her MSc Nursing from Rajiv Gandhi University of Health Science. And also she has nearly 9 years of experience. And now she is working as an associate professor in T and TV School of Nursing. So handing over to Ms. Tanvi.
Please share her content, sir.
Am I audible?
Yes, yes. Is this visible?
Mitesh, it says that I'm not able to share. I could not able.
I've shared my screen. Is this visible?
No, it is not visible.
It is not visible.
Manjunathan sir, please share now. I have stopped my sharing.
Okay, now it is visible, sir. Now.
Please go ahead.
Okay, good afternoon, everyone. And thank you so much, first of all, INS Society, for giving me this opportunity. Today, I'm going to deal with peripheral IV infiltration and its management. Some basic information I will give. So first of all, what is, we can say, the peripheral IV infiltration, means the meaning. Can I have the next slide? Okay, thank you. So IV infiltration is one of the most common problems that can occur when fluid infuses into the tissue surrounding the venipuncture site. When we are inserting, we can say the vein cannula, we can say the IV cannula. That time, if the IV cannula will go out of the vein, that time, or because of any other conditions, sometimes whatever the IV therapy or the fluid we are giving to the patients, that will come out of the vein. We can say the leakage can occur, and because of that, the fluid is collected into the surrounding tissue. That condition is called as IV infiltration. This sometimes happen. This sometimes happen when the tip of the catheter slips out of the vein. The first, we can see the picture is showing that the catheter is out of the IV cannula is out of the vein, and second picture shows that one of the patients who having the IV infiltrations. So as you can see, these conditions can arise. Now next we will see some causes of IV infiltrations. So first cause is catheter punctures the vein wall, as already we have discussed, that when the catheter pushes through the other side of the vein, when we are inserting the cannula, what occurs sometimes, because of maybe the movement of the patients or because of maybe some other reasons, the cannula will go out the vein, can occur at a time of insertion. When we are inserting, that time this thing can occur, or when sometimes what will occur when we have inserted, that time maybe it is in proper position, but because of maybe any other reasons or patient's movement, it will dislodge, right? So it can occur during the insertion time also, or maybe after the insertion. Result of patient's movement, IV can dislodge. This is possible. If we can say the when it will occur, when we are inserting the cannula, especially in the site where the patients can flex his or her hands, we can say, or we can say the legs. Now leakage from the insertion site. Sometimes what will occur where we have inserted that cannula, that vein area, from that area sometimes the leakage can occur. Now this leakage, when this leakage can occur, so this leakage can occur when there is a, we can say the restrictions or some clots is there into the vein that will block the fluid to go inside the vein. So that time what will occur, the fluid will leak into the surrounding tissues, and these conditions may arise. Now next is catheter back up out of the insertion site. The catheter exits the vein completely sometimes, or usually happens when the patient's movements dislodge the IV catheter. This already I told that when the patient moves the hand, that time we can say the condition is very common in the hyperactive patients. So that time we can say the IV cannula can dislodge from the vein. Vein fragility, sometimes we can say the structure of the vein is not able to handle the fluid. So that times the fluid will come out from the vein wall, the leakage will be there. So this occurs most frequently in the elderly patients. In the elder patients, we can say that vein will become too much fragile. We can say that time the vein is unable to handle the fluid. So that fluid will come out of the vein wall and accumulated into the surrounding tissue. Next is increased vein porosity, usually due to inflammation, which widens the gaps between the cells of the vein wall, allowing the fluid to leak out. Sometimes because of inflammations into the vein, what will occur? The gaps between the cells can widen. And because of that widens, we can say the gaps, the fluid will leak out of that gaps, and these conditions can arise. Now next is these are the, we can say the some of the Now next is the major sign of infiltrations include, as already we know that swelling at or near the IV site where we have we can say the inserted IV cannula, either it is in the hand or maybe into the leg. The surrounding area we can visible we can say the swelling will be there. The skin will feel too tight and pull to touch. Some patients experience intense pain or burning, while others may just feel slight discomfort. It is depend totally on the severity of the conditions. If it is a, we can say the mild form, we can say the patients may feel slight discomfort. If it is a very severe form, we can say the patients may feel pain, or maybe the patients can feel burning sensations also. Skin discolorations can occur. Then numbness of that particular part where this condition arises, the patients will feel numbness. Impaired blood circulations because of inflammations, we can say there is a pressures will created into the blood vessels, the other blood vessels. Because of that, maybe sometimes the circulations also impaired. And the symptoms the patient's experience often depends on the severity and length of the infiltrations. As I already told that, if sometimes if it is a mild conditions, we can say mild or moderate, the patients may just feel discomfort or maybe little bit pain. But if it is a, we can say the severe conditions, the patients may feel too much pain or burning sensation. So it is depend on the severity of the condition. Next. Now we'll see some side effects of the this IV infiltrations. When the IV fails or goes bad, means if the fluid will IV cannula is not in proper position, that time there are a variety of complications and the side effects that may set in depending on how the IV failed and how long it takes to discover and treat the issue. So it is depend on the IV, we can say the how much it is failed or how much the serious condition. IV failures involve severe complications like extravasations, particularly from chemotherapy drugs, as we already know that this condition is very common in the patients who are receiving the chemotherapy, right? So in that kind of patients, we have to take much care. Can leave permanent damage, including third-degree burns or necrosis. Sometimes if the condition become very severe, that time the permanent damage can also occur. So it is a duty of the nurse, or we can say who is inserting or giving the IV therapy. They have to be very careful when they are giving IV therapy to the patient. Next, please. First complications is, we can say, the compartment syndrome. This is, we can say, the rarely it can occur, but if the conditions become severe, that this complications may occur. So what is compartment syndrome? Compartment syndrome is a painful and dangerous conditions caused by pressures build up from internal bleeding or swelling of tissues. If there is a bleeding or maybe the swelling may be because of these IV infiltrations can occur. So the pressures may develop. So muscles in the patient's hand, this condition is very commonly occur into the hand, forearm and lower leg. This area, we can say, they are surrounded by the tissues. These tissue bands create a compartment. These muscles, we can say, it is made up of tissue. And too much fluid in the tissue.
Sorry. You have 3 minutes more.
Okay. So next is the skin burns. Compartment syndrome is next. Next is the skin burns and necrosis, or sometimes if the conditions become very worse, the amputation is also we have to do to protect the patients. Next, please. Permanent nerve damage also can occur. This condition is also rare, but it is a severe, we can say, the condition. That time also again, the numbness is there, tingling is there, even there is a loss of function is there into the, we can say, the where the this infiltrations occur. Sometimes because of medications dosing error can also occur. That will be also become complications sometimes. Next slide, please. Treatment. Now, what is the treatment? In that first one is the immediate treatment. Immediately what we have to do, as we know that patients having the infiltration, first of all, as a nurse, have to stop the infusion therapy, remove the IV cannula as early as possible, mark the outline affected area marker, take a photograph of that area or send it to the physicians. So we can start the any other, we can say, the form of treatment to the patient as early as possible. Apply hot or cold compresses based on, we can say, the patient's conditions. Then elevate the patient's extremity. Inject medications according to the doctor's orders. Next.
Now, this is not a condition that can be recovered into the, we can say the 1 day or 2 days. Some aftercare or continuous management is required. So continuously here we have to give the hot and cold compressions to the patients. Rest and elevate the arm to reduce the swelling or pain. We can keep, we can elevate the patient's arm. Maybe we can use the pillow or extra blanket so we can elevate. Protect the area from sunlight, as already the patients having the burning sensation and our skin will become very fragile. So we have to protect it from the sunlight. Check with the doctors about what hygiene products can be used for the patient, so as much as we can give comfort to our patients. If you observe the fever or any other sign of infections, you have to immediately inform to the clinician. Next, please. Now, IV infiltration prevention. As we all know that prevention is better than cure. So for prevention, it is in our hand how we can prevent the condition. So first is choose the appropriate vein and catheter. According to the vein, we have to choose the cannula. Avoid areas of flexions where insertion, where we are inserting the catheter, so it will not go out. Obtain assistance when inserting the IV in a hyperactive patient. When your patient is very active, hyperactive, we can say, that time you can take the assistance while inserting the IV cannula. Secure the IV catheter properly. Protect the IV site from excessive movement or pressures by the use of arm blocks or restraints. Sometimes we can make use a restraint also for the less movement of the extremities. Assess the site frequently. As we are giving IV therapy, that time we have to assess frequently. Educate the patients the sign and symptoms of infiltration, so patients can also notify us that something going wrong. Be careful not to make any sudden movement during insertions or during IV therapy. We have to inform the patients and make the doctor or nurses aware of any chronic conditions like diabetes or hypertension. If it is there into your patients, you have to inform to your doctors, or the patient has to inform to the doctor or nurse so they can take the appropriate measures. So this we learn about the what is IV infiltration. It's the simple form we have taken about the treatment and some prevention measures also. If you have any doubt, you can ask me. And thank you all for listening me.
Thank you very much. It's a lovely session, wonderful session. What we can do, we can once again, we will keep your and Mrs. Nirali's session only for any other than INS forum. It is a very lovely session. We are in a hurry. Wonderful session. Thank you so much. Even to Mrs. Nirali.
Thank you, Tanvi. Really, as Papia Madam said, it is a wonderful session. The only concern is here the infiltration and extravasation. When the infiltrations were there, of course, the extravasation probably it takes place when the infiltration is not timely remove the fluid on the excluded area. So when the extravasation will take place, then it become the ulcerations. As research statistics says, the 30%, 32% of infiltrations were happen and 29% of extravasations were happened. So when the extravasations were not taken care, it become ulcerations. A small cannula can lead a disable or loss of extremity. So this is how I can recall Madam Trupti as well. The Tejil said their earlier days, the IV cannula were the simple procedure. Now it is started as the US and affiliated into the India and taken a big chapter and implementing across the standard into the clinical area. So this is how it is erupted, because the simple cannula can lead to a disability or loss of extremity. So the wonderful presentation, and yes, as said Papia ma'am, we will take all the PPTs, we will circulate across our MC members. Thank you very much. A long waiting. Our beloved doctor, always the nurses have a very good association with our consultant, a very good doctor. Always we do call in the name of the doctors are the brain of the hospital and the nurses are the heart of the hospitals. Yes, of course, it is rightly said. The connect between the head, heart and hands to deliberately percolating the services and the practices across the patient services, it is rightly said. And with all due respect and honor to welcome Dr. Pinaki, and he has completed his MBBS and MD from MS University, and also he has completed his DM in medical pediatric oncology, and Hematology from Gujarat University. Currently, he is working as a consultant at HCG Cancer Hospital, Vadodara. Welcome you, doctor. It is such a privilege to have you in the forum, and we all eagerly waiting for your presentations. Thank you very much. Dr. Pinaki, you are there? Dr. Pinaki, are you there in the line?
नहीं आ रही है, फिर से एक बार.
But he's not there actually. Can you connect with him, please?
He is connecting. He is telling something. Am I audible? But not able to join.
Ask him to discontinue and
yeah, sure.
Yeah, ask him to discontinue and add once again. Audience.
He's reconnecting again. Meanwhile, you can take the question for the rest of the speakers. There are few questions. Yeah.
Audience, all our beloved participants requesting to be online. And if you have any questions, please drop into the chat box, and we will take it happily to share the answers.
There are 2-3 questions. Kajal is asking something. So just
not find actually. I'm not able to find Mitesh.
So this is a question from basically Kajal. She's asking to Nirali Patel. So she said, how many hospitals currently using those novel technologies? So Nirali, could you attend this question? What do you feel? How many hospitals in Gujarat, if you can say the Gujarat setup, how many hospitals are using these all our technologies? Nirali?
I'll take this question. As Kajal rightly asked, and appreciating Kajal. Kajal, this novel technology, it is nothing. Just giving attention on the way you handle the insertion and finding the lever locks and appropriate insertion, and finding and inserting the bevels on the place, and finding the placement of the tegaderms on the place. So these things only we call it as the novel technology. In addition to that, now the advancement, it's called as preventing the air bubbles not to enter into the IV lines, and also the IV cannulas, which help us to not to pierce the lumina of vessels. So these things only the novel technology. It is always, the basic is basic. The traditional way what we follow, we need to follow. So all these technologies across all the hospitals are following religiously nowadays. So it is prevalent among all the hospitals. All are following as religiously said. Thank you. What about Dr. Pinaki? Pinaki have joined?
There is some technical glitches I can find.
Requesting all our participants to be online, please. There is a technical glitch. Mitesh, can you call him and
Yes, I
ask
am in connect with Dr. Pinakin. He is connecting. Just a moment.
Am I audible, sir?
Yes, sir. Yes, sir.
So basically, we had linked in through our computer, and it was not, the audio was not going through. Can I share the screen from my side, sir?
It is already been shared, sir. You just follow this pattern, I mean.
Okay, no problem. So first of all, thank you, INS, for inviting me to host this lecture on post IV infusion observation. So I was listening very keenly to the previous experiences in the lectures, and really you have done an excellent work. The topic that I have been given, actually is quite on similar lines to what the previous lecture was about. So we know that the indications for IV therapy are to provide water electrolyte nutrients to replace water and correct electrolyte deficits and to administer the medication. So I, being a medical oncologist, we are dealing with chemotherapy, which is one of the most toxic medicines that are there and which are very, very liable to cause complications. As has been aptly described in the previous session, what are the complications? So my take would be from the doctor's side, how we can, deal with these things in a timely manner, and what are the things that we can do to prevent and treat it. Next slide. So we know the routine IV solutions. Next slide. So there are some solutions, obviously, like potassium, where we have to be very sure how to give it, because we know that potassium is very, it can be very painful if we are transfusing it very fast. And obviously, there are the side effects like cardiac asystole as well if we give potassium very fast. Next slide. So whenever we are giving potassium, we have to remember that the vein has to be a central vein or a large vein, and the transfusion rate has to be very, very keenly monitored, has to be very acutely monitored, because it can lead to cardiac asystole as well. So definitely, this is something I think which we are very, very careful about whenever we are using potassium. Next slide. This has the general principles of post-infusion observation. So we know that whenever we are cannulating, we should be careful about selecting the site of cannulation. It should be as distal as possible and not over the joints. So selection of the cannulation site probably makes a lot of difference in the eventual outcome. Next slide. Definitely, we do not cannulate, especially in chemotherapy, we do not use the lower limbs for chemotherapy. And we avoid the sclerosed or the thrombosed veins, and avoid the veins with arteriovenous shunt and fistula. One of the important things is patients who have had surgery done on, let's say, breast cancer, where we tell the patients that we cannot use the operated side upper limb for any kind of infusion, or even for blood collection. Next slide. So in our practice, we often tell our patients to basically go for the central venous access devices, because we know that chemotherapy, repeated infusions of chemotherapy can damage the veins and lead to extravasation. So one of the good options is to go for a peripherally inserted central catheter, that is a PICC line. So this is basically to be inserted by a trained nurse, and the other option being a port insertion. So PICC line insertion is something which we usually follow because it's a OPD procedure, and generally we have a trained nurse or an intensivist to insert the PICC line just before the chemotherapy. And with proper care, we can use the PICC line for up to 6 months. Even the port catheter that was shown in the previous slide is something which we commonly use, and the lifespan of this port is almost 2 to 3 years. So routinely, we have to encourage our patients to use more and more central venous catheters, because that is actually the primary way in which can prevent the complications associated with the infusion of chemotherapy. Next slide. Again, this is administration of IV fluids. So we have to be very cautious while giving all these IV fluids, especially chemotherapy. We have to adjust the rates accordingly. Each chemotherapy has got its own unique way of administration, and we should be sticking to the time schedules and the proper method of giving it. Next slide. Common complications, as I said, has been described quite aptly in the previous lecture, but I'll just go through it briefly. Next slide. So phlebitis or inflammation of vein is very, very common, and it is very important that we distinguish this from extravasation, because the two are quite different. However, the degree of injury can be varying in different patients. So signs and symptoms of phlebitis are redness, swelling, pain, and edema at the insertion site, and the treatment is generally the removal of the IV site. Now this is, next slide. So when the phlebitis happens to a greater extent, or when you're using a irritant or a vesicant chemotherapy, there are more chances that you will have an extravasation or infiltration, or when there is a dislodgement of the venipuncture device from the vein. Next slide. So you have to distinguish between phlebitis and infiltration. It is very important, because most of the patients are going to have phlebitis but not infiltration. These are the ways in which, these are the subtle signs in which we can see whether there is skin blanching, skin coolness, leakage at the puncture site, and absent backflow of blood. So this is more likely to be infiltration and phlebitis. So we know that extravasation is the inadvertent administration of drugs into the surrounding tissues rather than into the intended vein, and it's a serious complication. And especially with chemotherapy, this is a very, very important complication to take note of. Next slide. So we generally have our chemotherapy drugs classified into different categories depending upon the potential to cause extravasation. Very important to note that the vesicant drugs are ones which are more likely to cause tissue damage, and we can divide them broadly into two categories, that is the DNA binding agents and the non-DNA binding agents. Why this is important is because the management of the two is radically different. So we should be knowing about the non-DNA binding agent, that is the vinblastine, vinorelbine, vincristine, and the DNA binding agent, that is mostly the anthracyclines like adriamycin, doxorubicin, epirubicin. Next slide. And there are other classifications depending upon the degree of irritation or the damage that the veins can cause, that is the irritants and the exfoliants, the inflammatories, and the neutral drugs. But these are less important as compared to the vesicants. So as I said, the reactions that can happen post-infusion might be a venous flare or a vessel irritation or a venous shock. So there are again different terminologies for these, but the point is that extravasation is the most serious complication, and that should always be kept in mind while doing this. So venous flare might be there and irritation might be there, but the most important complication. So next slide. Okay. So I've just described the drugs here in short. What are the different drugs that can cause the problem? So most important is basically the vesicant drugs, and the vesicant drugs have the most potential to cause extravasation. So whenever we are using these vesicant drugs, our staff is extra careful to see that there is no signs and symptoms of extravasation. Next slide. While the other drugs, if you look at the neutral drugs and all, they are not that much problematic, but obviously with any IV chemotherapy infusion, we should be careful that it does not proceed into the other kind of reactions. Next slide. As I said, there are two broad categories, DNA binding and DNA non-binding. The management will differ as I will describe. Risk factors, we know that small fragile vein, multiple treatments, generalized vascular disease, impaired lymphatic flow, or some SVC obstruction might be there, especially in malignancies. This is very common. Others being locally infiltrating tumors, very elderly or very young patients, insufficient patient information is restless or confusion, impaired sensory perception, and so on. Next slide. Previously received multiple lines of chemotherapy, insufficient training of the staff, and organizational issues. Next slide. For minimizing the risk of extravasation, obviously we should not cannulate over the joint spaces. Ask the patient to report any changes in the sensation. Never cover the cannula with a very bandage while it is going on. Dilute the irritant drugs. Whenever possible, administer the vesicant drugs as a bolus. This is very, very important. Whenever we give vesicant drugs, we should always use a bolus infusion. Check for the swelling, inflammation, and pain around the cannula site. And obviously, the patients who are more susceptible, we should be especially vigilant. And the central line should be used whenever it is possible. Next slide. Next slide. And I think these are the other general guidelines, that we should use a small gauge needle as small as possible. Ensure that the IV site is clearly visualized, and site and secure the cannula so that it cannot get dislodged. Do not begin a new infusion for the drug administration. Do not use a scalp needle. Again, this is very important. We should not use a scalp needle for chemotherapy, especially if you're using a vesicant drug. And the line should be free flowing, and we should always be sure to flush the line after we have finished the chemotherapy. Next slide. For the central venous catheters, we generally will ensure that the backflow is there. If suppose sometimes it is possible that you might not get a backflow, but in that time, you should always infuse an extra 100 ml NS of some bolus fluid and see whether the flow is free. And sometimes we also see that there are postural changes while the patient is taking treatment. So we have to adjust the appropriate position and be extra vigilant about the chances of extravasation. Next slide. Next slide. Next slide. So as I have already described this thing, so you can just go on, sir. Next slide. Next slide. So whenever extravasation happens, what we should do is generally stop the infusion immediately, wear the personal protective equipment while dealing with extravasation. Do not remove the cannula. We should not remove the cannula. Disconnect the infusion. Connect a 10 ml syringe and attempt to aspirate the residual medication from the site. This is very important. Do not exert any pressure on the extravasated arm. Elevate the arm and immobilize, and follow the instructions that are specific for that medication. Next slide. Assess the site for pain, erythema, induration, necrosis. Administer pain relief. Document the incident. Mark the affected area. Photograph the site if visible, and follow the patient closely. This is also very important because sometimes the signs of extravasation might be mild, and with time they progress. So we should be following up the patient very closely. Next slide. And as I said, specific drugs have got specific antidotes. Next slide. So we have got warm and cold packs basically. So the cytotoxics that require the warm pack include vincristine, vinblastine. These are the drugs where we have to use warm pack, and we have to also use hyaluronidase whenever it is required. While the cytotoxics like doxorubicin, epirubicin, they will require cold pack, and in that case, a cold pack should be used. So this should not be mixed. Whenever we have to use the warm pack, it is advisable to use the same and not the other one. So one has to be aware of what are the different kind of toxicities depending upon the mechanism of action, and according to that, a specific antidote should be used. We have got some antidotes like DMS and all, but they are not readily available. So the primary precautions has to be managed properly rather than going for the specific antidote. Next slide. Again, I think it has been described. Next slide. Next slide. Next slide. Next slide. And this is something previous slide. Yeah, so an extravasation kit is very important tool that one must have whenever we are using chemotherapy in the daycare, and this has to be audited regularly because this is the primary prevention and the primary treatment of the extravasation that has to contain all these things like hyaluronidase, steroids, sterile water, hot pack and cold pack, spare gloves. So all these things have to be documented properly, and these things have to be made available because extravasation, whenever it happens, it can lead to loss of limb, sometimes even loss of life. So one has to be very careful about this. I would like to conclude my lecture by saying that, as you have said, that IV cannulation looks to be a very simple procedure, but can lead to a lot of misery and a lot of complications. Similarly, extravasation also is something which is very, very painful and has a lot of misery associated with it. So definitely we should be do our all to prevent this complication. Thank you so much, sir.
Thank you, Dr. Pinaki. You really highly appreciating because you have taken our invitation positively and you have prepared a wonderful slides, and it is really yeah, very informative. And all our participants, our panel members, on behalf of INS and Colonel Binu Sharma, thanking you from the bottom of the heart, because joining with nurses by doctor is always, you know, a very good package. So I would this is a time I have to take Mitesh He's the one, the backbone who always push all of the MC members, being on your toe and making active always this INS in Gujarat region. So thanks once again to Mitesh, and thank you very much to Dr. Pinaki. Nothing to moderate here, because you have delivered a wonderful informations and shared a very good practice, what it is exactly it is on floor. Thank you very much once again, Dr. Pinaki.
Thank you, sir.
So any questions from participants, please? If you have any kind of concern or the questions, please drop down in a chat box. Or else you can unmute your speaker and you can speak out. The speakers are able to answer all your questions.
Only participants, I mean the panelist can speak. Rest of the participant can just type in question answer box, either
Sorry,
chat box.
requesting
Yes.
participant to drop your all concerns and the doubts in the chat box, please. I think we will wind up. So timely, we are, completing the session, because there are the technical glitches in between, but still we are in time. Thank you once again to all the panel members and all our own family MC members who have contributed their time and they prepared themselves and shared their existence, practice, and the concurrence. Thank you very much once again. And over to Pape ma'am.
Thank you, Manjunathan. And thanks a ton to Dr. Pinaki. It's a wonderful session. And I'm also from HCG. So we are expecting that every time, whenever there is a INS session, we will get you again and again. And all the participants, lovely sessions, and all the speakers. And special thanks to Manjunathan for moderating show well.
And
So
there
we are
is
Yeah, I know, Mitesh. Yes, yes, ma'am. Shall I continue, ma'am?
yes, you can continue.
Yeah,
It's
So without the session, without our the backbone of the Mitesh, it won't be possible to close. There is none other than Dr. Arijit Guha. Inviting him for the forum to giving a closing remarks. So please, sir.
Am I audible?
Yes, sir, please.
First of all, heartiest congratulations for the first formal INS chapter meet in Gujarat. So, heartiest congratulations to all the leaders, Papi ma'am, to you, Manjunathan, to you, and to Mr. Ullas and all the other MC members. It's really heartening to see how, and Colonel Binu Sharma covered it in the beginning, that how it has very, very determined, in a very determined way, how this organization has moved one step at a time forward. So it really gives us a lot of pride in associating with all the leaders here and all the delegates who have returned back again and again to hear all the leaders in different forums in INS. So, and today, after hearing to all the speakers, it really gives a lot of confidence that, the direction is set, the goals are, aligned. I think that from here onwards, we'll only hear lots and lots of success stories. I'll have to revisit some of the pillars wherein this convergence is happening. We are looking at safety in IV practices. And so safety in IV practices could be delivered through policy and protocol changes. Number two, technology adoption or technology absorption. And third is the education, skills, trainings, etc. So, and all these things, when they converge together, the outcomes are really the best for the patient. They are safe IV infusion for the patient. And today with INS, the guidelines, the resources, what to do, how to do, everything is available. The technology is available. The industry partners are there to make them accessible to your practice. You as leaders are the change champions. You are there to adopt these technologies or these education skill upliftment for the upcoming nurses. So I think with all these things and the discussions that they have happened, I think it's really, really heartening to see. And going forward, all there is a certain convergence in all these three areas. And on behalf of the industry partners, especially Polymed and Mitesh and Pooja and the Gujarat team, I know that how hard they work in the back end to make this happen. And to all the nursing leaders and the MC members, um, I wish you all the best and really look forward to the upcoming chapter meetings. Thank you very, very much.